Hi, welcome to this educational activity at the Nexus of Local, Regional, and Systemic Liver Cancer Therapy, a multidisciplinary tumor board on improving outcomes in intermediate to advanced HCC. I'm Dr. Richard Finn from the David Geffen School of Medicine at UCLA, and I'm joined by my friends and colleagues, Dr. Matthew Johnson from the Indiana University School of Medicine in Indianapolis, and Dr. Laura Kulick from the Northwestern University Feinberg School of Medicine in Chicago.
Thanks, Rich, and it is a pleasure to be here with you and Laura, and a pleasure to talk about the treatment of patients with liver cancer. This slide is fairly basic, but shows the treatments for people as they move through the BCLC staging and treatment algorithm. We in IR have had a preeminent role for years, decades, and for a long time we provided the only therapy beyond resection and transplant because systemic agents weren't terribly effective. That changed with sorafenib, and we then were trying to figure out ways that we could work with people providing sorafenib to provide good care to patients. It changed a lot in the last couple of years when really good systemic agents came on, and they're supported by really good studies. So we have now a very changing environment in the management of patients with hepatocellular cancer. And it's important that we figure out how to treat our patients well within that environment, because even though we're doing a good job, the mortality of patients with liver cancer is increasing. The incidence is increasing and the mortality is increasing. So we can do a better job. And our goal would be to treat patients earlier and get them toward curative therapies. Or optimally, take people who are further along to the right in the algorithm and move them toward the left, or stage transition, and prevent stage migration. The way to do that is working together. And so that's what this symposium is all about, is optimizing our care of patients by working with every member of the team and trying to figure out the best synergies between what we can provide. And so with that, I will move on to the first patient to discuss. And both of the patients we'll discuss are mine, and they're real. And the first patient is 58 years old. She had cirrhosis for several years and required her first paracentesis only a few years ago, after which her ascites was treated with diuretics. So she had one paracentesis, now has ascites, treated with diuretics, and at the time of her diagnosis and up until this point, she had no known varices. Her labs are as stated, with a platelet count of 107, INR of 1.1, creatinine of 1.03, ALK-Phos 289, ALT 49, AST 69, bilirubin 1.7, albumin 3.1, and AFP 334. Her ALBI score is negative 1.67. So together, she's a child Pew B7, and being followed, and surveillance ultrasound in November of 2019 showed liver lesions, so she was sent to us for further evaluation. The December 11/19 CT scan demonstrated clearly an hepatocellular cancer in the left lobe of the liver and several sub-centimeter lesions throughout the rest of the liver. The smaller slides also show the presence of varices on the bottom right of your screen, unknown up to that point. We went to Multidisciplinary conference and decided that she would hopefully make it to transplant, and we wanted to try to stabilize her largest tumor, keep her within Milan, and then work toward getting her transplanted. So this is from the staging arteriogram on February 20th. She delayed because of COVID to come into us, and we eventually did get her in, and you can see the large hypervascular tumor in the left lobe. It was actually fed independently by segments 2 and 3, so I treated both of them. And this is the post-radioembolization PET scan, and you can see good targeting of that tumor, and it actually hit the smaller tumor that was caudal to it and posterior. And the smaller slide just shows the correlation between the post-yttrium PET and the CT prior. She did very well with that, and her largest tumor decreased in diameter and no longer was vascular after that. And you can see multiple hypervascular nodules in the right lobe of the liver, all sub-centimeter and not changed from prior to her radioembolization. So we thought that was great. We started her evaluation for transplant, and in December, 7 months later, everything looked about the same, and her AFP was still 107. It had never been above 150 after treatment. So at this point, she's on the list, and she just came back for a follow-up study about a few weeks ago. And unfortunately, even though the tumor that we treated with radioembolization is gone, those sub-centimeter nodules have increased in diameter, and her AFP is up to 701. So she has developed multifocal hepatocellular cancer that is now diagnostic of that. So we, up to this point, did not have her on systemic therapy. It was discussed, and we didn't have her on systemic therapy. But before I get to that, I should probably have asked a more important question, or at least a question of a more general nature, and that is, if she were child Pu-A at diagnosis, would that have changed any of your treatment options? What would it have changed for this patient? And I'll ask that of Laura.
So given that she is young and her AFP was relatively low when she was diagnosed, and she'd already had some complications of liver disease requiring a paracentesis, I think the goal would be to get this woman to transplant. So I think I would have probably done similar to what you guys had performed, with the goal of bridging her to transplant, regardless if she was an A or a B.
Thanks. And the reason I asked that one first is that the next three are best answered, I think, by Rich. So the first question is, what would you have decided earlier to move on to systemic therapy for this patient?
So I think, to Laura's point and how you guys manage her, our goal is cure, and if we could get the patient a transplant, that's great. But as patients are waiting, their tumor biology will declare themselves. And I think as this patient advances, and what I've often said is patients who have intermediate liver cancer, if they don't get cured or die of some other comorbidity, they will stage progress to advanced disease. And I think when we start seeing multifocal disease in the liver, in both lobes, we start to get concerned that local regional treatment won't be enough. And now, as you alluded to, we do have very good medical treatments available, not only front line, but second line, and potentially even third line. Given all of these have been studied only in patients who are child Pu-A, and so the safety and efficacy of some of these regimens has not firmly been established. For patients who are candidates, atezolizumab and bevacizumab has clearly established a new standard of care for frontline liver cancer. One of the things we do get concerned about is this risk of bleeding. And in the IMbrave 150 study, all patients were required to have an endoscopy within 6 months of starting. And many patients did have varices. Some of them had to have them treated. But as long as they were not high risk for bleeding, then they were allowed to come on study. And, you know, we can't forget that there's a whole lot of regimens on the horizon. New combinations and ongoing clinical studies, which we should always consider how to get patients into these clinical trials to do better. But again, most of them do require patients to have good performance status in child Pu-A liver disease.
Well, what are the considerations for treating the varices before starting on atezolizumab and bevacizumab?
So not all varices need to be treated. Obviously, we defer to the endoscopist if they're at high risk for bleeding. Small varices probably do not need to be treated. But if there are varices that are at high risk for bleeding based on the endoscopist's assessment, then those should be banded. And then probably it's prudent to wait a week or two before starting the Bev. But this is a minor procedure, and in reality, unless they're, again, high risk for bleeding, atezo-bev should be considered a treatment of choice for advanced liver cancer. You know, there's been a lot of advances in liver cancer treatment, and this slide comes from the NCCN, which highlights the role of atezolizumab as a new option for patients, as well as what we have is the established TKIs of sorafenib and lenvatinib. Interestingly, they maintained a potential recommendation for nivolumab, even though there was a phase 3 study of nivo versus sorafenib that did not meet its statistical endpoint. But we did see nivolumab had a response rate of 15%, was well tolerated, and a survival of over 16 months. It just was not statistically different than sorafenib. And that would be for patients who can't tolerate any anti-angiogenics. But for the large majority of patients, they will probably be candidates for atezo-bev if they're candidates for systemic treatment. And this study was published in New England Journal of Medicine last year, where it met both its primary endpoints of improving overall survival and progression-free survival. And at the time of the initial analysis, we did not reach the true median in the treatment arm. We did have a hazard ratio of about 0.58 that was stable and significant. And at GI ASCO now, with an additional 12 months of follow-up, we see that the new frontline survival for advanced liver cancer is over 19 months. 19.2 months with atezo-bev, and the sorafenib arm did not change. That was 13.4 months. The PFS data was very stable because we had reached those medians at the time of the primary analysis. And what was very striking is that with longer follow-up, we've actually seen the response rate go up. At the time of the primary analysis, the response rate with atezo-bev by conventional RECIST was 27%. And now with longer follow-up, we see that response rate is 30%, including 8% complete responses with systemic treatment. And this regimen is pretty well tolerated, I would say. We don't see any new safety concerns with longer follow-up. Obviously, the autoimmune phenomena, which we are familiar with PD-1 or PD-L1 inhibitors like atezolizumab, can be seen, but generally they're low grade. Really, a lot of the side effects we've seen were related to bevacizumab. And we see that here on this slide, where looking at the safety of bev versus sorafenib, you can see the most common side effects with atezo-bev were hypertension and proteinuria. And in this slide, all grades are lighter, high grades are darker. But things that the patient really notices, such as diarrhea, hand-foot skin syndrome, anorexia, are really more common with sorafenib. And this type of data was very much supported by improved quality of life assessments with atezo-bev over sorafenib. There is similar bleeding risks with both drugs. Most of it is low grade, such as epistaxis. There were more higher grade bleeding events with atezo-bev, but again, this can be mitigated by patient selection. Good performance status, Child-Pugh A, and doing your preoperative endoscopies, or pre-treatment endoscopies, I should say. Now, single agent PD-1 inhibitors have had challenges in phase 3 studies. Both nivolumab and pembrolizumab have accelerated approval for progression after sorafenib. Now that we've seen IO move to the frontline space, the number of patients getting this beyond progression, I think, will be fewer because the patients who will get this will be the ones who get TKIs in the frontline. And again, atezo-bev is not going to be for every frontline patient, but I think it'll be the majority. Maybe some of us estimate around 15-20% of patients might not get atezo-bev frontline for various reasons. And if they get a frontline TKI, a progression, both pembro and nivo would be appropriate, as both of them gave response rates of about 15 to 20% that were very durable. The thing is, as you see here in Checkmate 459, nivolumab did not reach its primary endpoint of improving PFS statistically in the Checkmate 459 study. And interesting enough, at GI ASCO, we saw data from the single-arm Keynote 224 data, a subset of patients who had got pembrolizumab frontline. Again, an uncontrolled study. And again, similarly, the survival was 17 months. So very similar data that, single-agent checkpoint inhibitors are active. We just don't have level 1 evidence. And there's ongoing studies, a lot of exciting combinations. Those include dual inhibitors of 2 checkpoints together, such as durvalumab and tremelimumab, which is PD-L1 and CTLA-4 combinations, or Checkmate 9DW, which is nivo and ipi, and that's PD-1 and CTLA-4 combo, and some combinations of immunotherapy and TKIs, such as atezolizumab and cabozantinib, which is already approved in second-line cabo, and LEAP-002, which is pembrolizumab and lenvatinib. So we've seen some early phase data with these combinations. This study from ASCO of last year looked at tremelimumab and durvalumab in various arms, looking at different dosing strategies or single agents versus combinations. What's very interesting is this dosing here with a single dose of tremi at 300 plus durvalumab gave overall response rate of 24% in second line with a duration of response that still had not been reached, and a median survival of just under 19 months in the second line population with a tolerable safety profile. And this regimen is being compared to sorafenib in the Himalaya study, and we're waiting for those results. There's also several early stage studies with this combination, in combination with TACE or after resection or curative RFA. Looking at these study designs here, you see Himalaya with Durva versus Durva Tremi and sorafenib, and Checkmate 90W with Nivo-Ipi versus sorafenib or lenvatinib. And we should comment that Nivo-Ipi itself is approved now in the United States for second line. It has accelerated approval, and it is based on response rates of about 30%, and that is what's driving this confirmatory study in frontline. Also in frontline, we have the combination of lenvatinib and pembro. Now, lenvatinib is a multikinase inhibitor. It's approved frontline based on non-inferiority to sorafenib. And in this study published in JCO last year, we saw response rates, if you look at conventional RECIST, of 36%. Median duration of response is over a year, and a disease control rate of 88%. And this is very exciting data, I would argue. Median survival was 22 months. And again, this is a single-arm frontline study, but not too similar from the single-arm IMbrave 150 data or atezo-bev data that led to IMbrave 150. And this study has completed accrual, and we're waiting for results. And here you see the design of LEAP-002, which is len and pembro versus len. This is a placebo-controlled study for the pembrolizumab component. And Cosmic 312 is looking at cabozantinib, the VEGF receptor inhibitor, MET and AXL inhibitor in combination with atezolizumab versus cabo or sorafenib, which is really the control arm here. We don't have a lot of data on this combination in the public domain, but needless to say, many of the TKIs in combination with PD-L1 inhibitors or PD-1 inhibitors are showing very exciting responses. Now, we can't ignore the fact that we have several drugs available at progression. If we look at the IO approvals, as mentioned, Nivo and Pembro have approval, accelerated approval as single agents, and Nivo and Ipi now has an approval as of last year, 2020, for accelerated approval after prior sorafenib. And you see the response rates go up with the combination. There is more toxicity with the combination, about 50% in the combination in the phase 1b study actually needed steroids for immune-related adverse events. But needless to say, these are options for patients, and I think specifically for patients who do not get IO in the frontline setting. And also looking at second-line approved TKIs. Regorafenib was the first drug approved since sorafenib, and it was approved for patients who had tolerated sorafenib. It was approved in second line based on an overall survival benefit versus placebo, a hazard ratio of 0.63. Similarly, cabozantinib was looked versus sorafenib or after sorafenib progression. And interestingly, the Celestial study also had about 25% of patients who were third line. And again, an improvement in overall survival with a hazard ratio that's consistent, I would say, with the other drugs in the space, which also includes ramucirumab, the anti-VEGF antibody. So this is a monoclonal antibody to the VEGF receptor. This differs from bevacizumab, which is to the VEGF ligand. And in this study, patients had to have an elevated alpha-fetoprotein in order to be enrolled. So this is a biomarker-selected cohort where we saw a hazard ratio of 0.69 for this cohort. So risk reduction for death in this population of patients who have a worse prognosis based on the high AFP. And certainly the AE profiles of the TKIs are fairly similar: hypertension, hand-foot skin syndrome, diarrhea, anorexia. Ramucirumab as a monoclonal antibody has a little cleaner side effect profile and really is related to its VEGF receptor engagement. And we've seen things such as hypertension, proteinuria, and some fluid retention. So before we go on to the next case, I see there's some cases coming in or some questions coming in from the audience. And Matt, maybe this is a good one for you. As we talk about these newer combinations that are more active, how do you see them affecting where we stop LRT? You commented that before we had sorafenib, LRT kind of filled a void. Then we had sorafenib, which improved survival, but not a high response rate. And now we have a new generation of drugs that seem more active.
And it's a great question. But I think it's not really stopping LRT because local regional therapy has occurred. It's whether you do it again. And it's a different metric now. It's a different equation because if there wasn't anything else, then you would do the same thing. You'd pound your head against the wall again because it's the only wall you could pound on. Now it's not. Now if you've done something and it wasn't completely successful or it recurred afterward, you have to evaluate the patient at that moment and determine what's the best thing to do at that time. We don't know always what that is, but these drugs work. And so they should be actively considered rather than doing the same thing you already did that didn't work, that may have worked at one point but isn't working now.
Yeah, I think that's a good way to put it. And I would also remind the audience that, to have advanced liver cancer or liver cancer that's a candidate for systemic treatment, you don't necessarily need to have extrahepatic disease, right? Bulky, progressive disease in the liver post-local regional therapy would be something to consider for systemic treatment. Laura, you're a hepatologist. You're very involved in the management of liver cancer and this idea of transplant. What about this idea of IO agents and downstaging? What are your thoughts and concerns?
So it's something we have started thinking about. Certainly there are people who will have a very robust response and a sustained response, and should those patients be considered for transplant in the context that there's never been concern for extrahepatic spread. I think we need some more safety data. There have been case reports of patients undergoing transplant after receiving an IO and subsequently losing their graft very quickly. There is a recent publication, which was a letter to the editor that comes from the Mount Sinai group, where they had a total of 9 patients, of which 8 had received transplant within 4 weeks of their last IO. And they've only had 1 patient with mild rejection, and no one has lost their graft. So I think we need to start thinking about it, but we need to do it safely. These grafts are very precious, and we need to make sure that we are not putting patients at risk of a more quicker demise as a result of graft failure due to severe rejection.
Yeah, and I think we need to characterize who those patients are, right? I mean, I'm at a large transplant center, all of us are, and my sense is most patients can be controlled with local regional treatment, right? And who are those patients? To the discussion before, but here we're looking at curative intent. Who are those patients who we stop LRT pre-transplant and say, look, you're still a transplant candidate, but now you need systemic treatment, right? What's their clinical course look like? That I think we need to clearly define in order to target them. And it relates to our next question about safety. How does post-transplant status affect choice of drug? And I think this is referring to patients who have recurrent liver cancer after transplant. And I think many of us think that the TKIs are probably the first choice. Certainly the most safety data is with sorafenib. Whether or not these drugs work the same post-transplant, we don't have those data sets, but assuming they're not going to die of liver failure, we would offer these patients some treatment. And to Laura's point, I think now in the post-transplant setting, we need to be very careful with IO because, the question is, are we hitting the brakes and the accelerator at the same time? Meaning, patients are on immunosuppression, and then we want to give them drugs that activate their immune system, right? So maybe one of the first things is just to decrease the immunosuppression, see how they do. But I think IO in this setting is right now contraindicated. So for the sake of time, and there are good questions coming in, I think we will transition back to you, Matt, with your second case.
Thanks, Rich. And be interested to hear what people have to say sincerely, given that this gentleman just presented to me last week. And so his treatment plan isn't immediately set upon. He's a 61-year-old man with cirrhosis. His HCV is cured. He has a sustained viral response. He's otherwise totally healthy, save for iron deficiency anemia, for which he takes iron supplements. No significant past medical history. He's heavy, but other than that, and mildly hypertensive, but otherwise fine on physical exam. He has a platelet count of 106. His INR is normal. His sodium is normal. His creatinine is normal. His alk phos is 99. ALT 35, AST 63, bilirubin at the upper end of normal, and his albumin at the just below normal. So with an albumin of 3.5, he has a Child-Pugh A6. If it were 3.6, he'd be a Child-Pugh A5. So with that presentation as normal, he was found on surveillance ultrasound again to have liver nodules, so we obtained a CT. And he has a diagnostic appearance. Here are 2 measurable nodules in his right lobe. But unfortunately for him, he also has varices and more nodules. And down lower in his liver, he has not only nodules, but confluent disease, irregular infiltrative. So the mass there is measured a little over 5 centimeters. And I think it's best shown on this coronal scan showing a nodule up in the top of his liver, and then that irregular confluent infiltrative stuff at the bottom. Of note, his portal vein is completely free of disease. I show one picture with the main portal, but his right and segmental branches looked clear as well. But he does have extensive varices, as we have seen previously, this time gastroesophageal varices. So as I said, we've discussed what we plan to do with him, but I'd be interested to know what you guys think is the appropriate next step for him.
So I'll take a stab at that. For one, he's iron deficient, and we want to know why, right? Hopefully he doesn't have varices, but that would he'd have to have an endoscopy, because to me, this patient is like the patient we talked about before. They don't have extrahepatic spread. They have an ugly-looking, infiltrative, multifocal tumor in the liver. And I think this would be a great candidate for systemic treatment if they didn't have varices, atezo-bev. But obviously, a clinical trial might be appropriate as well if their physiology otherwise allows.
Thanks, Rich. Laura, how would you handle it? What do you suggest as the next step?
So similarly, I would want to get this patient scheduled for an endoscopy in a timely fashion, because if you are considering bevacizumab, you're going to potentially need to scope this person more than once, especially if they have large varices, which may be the case based on what we're seeing on the imaging, but not necessarily when you may not see that he's not risen to the surface of the esophagus yet. And also would want to consider does this person meet a clinical trial that's available, given that they have preserved liver function.
Thanks. And both of you mentioned clinical trials, and I'll tell you that that's what we're hoping to get him into, a trial of looking at TACE plus or minus systemic therapy. But that's just one of many trials. Any of you consider any other trials that you might want to enroll in?
Yeah, like there's studies now that are building on atezo-bev as front line, right? Atezo-bev plus a new drug. The benchmark of 19.2 months now in advanced disease is quite high. And if you look at this patient who does not have extrahepatic spread, does not have vascular invasion, that subgroup of patients with atezo-bev even has a survival beyond that as a subgroup. So, systemic treatments alone would be a very reasonable option for this patient. Again, if you have a trial with LRT, that's great. I would say if they're not in the study, I'd throw it back at you, Matt. Would you still give them LRT and systemic treatment, or outside of a study?
We're going to look at trials first, and then it is a question. It's about his preferences and ours. Local regional therapy is pretty well tolerated, so I don't think we'd be putting him at risk, and it might be helpful. I can't state that it would. The combination is better. That's why we need to study it. But I think we've got pretty great responses with radioembolization, even with infiltrative disease. So I think that is not an unreasonable thing to consider.
And I think, Laura, you're going to take us through some of the combination stuff, building on that case.
Thank you, Rich. So early on, the rationale for combination therapy with local regional therapy was predominantly done with sorafenib with chemoembolization, with the hope that the addition of sorafenib would block the angiogenic flare that we would see after TACE as a result of hypoxemia, with the hope that we would have an improvement in time to progression as well as overall survival. However, there were large phase 3 trials that were conducted primarily with sorafenib in combination with either conventional chemoembolization or drug-eluting beads, and unfortunately, none of these met their endpoints. There was some hope that the phase 2 trial Tactics, which had meant one of its primary endpoints of improved PFS, but overall survival had not been reported until recently at GI ASCO, and unfortunately this was not shown to improve overall survival. However, PSFs remain to be significantly improved with combination. Of note, the patients had more post-progression therapy in the patients who had received sorafenib alone. And now that we have immunotherapy, we are starting to see the combination with local regional therapy. And this is now an older paper. This is from 2017 using a CTLA-4 inhibitor. And what they did is they used sub-lethal either chemoembolization or RFA, and then gave a CTLA-4 inhibitor. And they purposely had biopsied areas that had not undergone local regional therapy and found that we saw this abscopal effect. So there was an increase in the types of T cells that we know will fight cancer, CD8 and CD3 in patients who had not received local regional therapy, suggesting that this combination was leading to an improvement in the immune response. But there are many questions that we still have unanswered. Is there one local regional therapy that will be more immunogenic? Do we need to aim for complete or sublethal necrosis? What's the timing between local regional therapy and systemic therapy? And can we come up with biomarkers to prove early on who is having a response? This slide highlights some of the early evidence for immunotherapy plus local regional therapy. In the PETAL trial, in the first cohort, there have been a total of 4 patients that were available for radiographic response. 3 had stable disease and 1 had progressive disease. Here we can see that there was no additive concern for increase in toxicity due to this combination. Another phase 2 trial is NASAR HCC, and this is looking at Y90 plus nivolumab. And here you can see there is a complete response in nearly 12% of patients and a partial response of 26.2 for a ORR of that was impressive, and disease control rate that was 81%. This highlights many of the ongoing trials that are looking at this combination. The first 3 on the top there are phase 3. We have some phase 2 trials. You can see that they're looking at combinations of IO and IO plus TKI. Most of these are with chemoembolization, and there is one looking at radioembolization. An emerging new local modality to highlight is called tumor treating fields, or TT fields. TT fields are low-intensity, intermediate frequency, alternating electrolytic fields that disrupt charged particles during the mitosis phase in cancer cells. The disruption affects cell division during the metaphase and telophase of mitosis, leading to targeted cancer cell death. This wearable, non-invasive device has been demonstrated to extend survival in difficult-to-treat cancers and is FDA approved for glioblastoma and mesothelioma. There is also a very helpful video that explains the mechanism of action of TT fields in detail that you can access as a supplemental resource with this activity. Please be sure to check out this video. So this modality is being studied for advanced liver cancer in a phase 2 trial. You can see in the image that the transducer arrays are placed around the abdomen targeting the liver location. At a frequency of 150 kilohertz, TT fields therapy is applied concurrently with sorafenib, and the overall radiographic response rate is the primary endpoint. Based on the results from glioblastoma and mesothelioma, we know that this device is safe to use and that there is little to no toxicity associated with this therapy. This phase 2 trial has completed recruitment, and we are awaiting the results this year. I just briefly wanted to mention the two surgical options that we know offer the potential for a cure, and this is hepatic resection. Hepatic resection, I've highlighted what has been the guidelines for many years. I'm not going to go over these in depth. I do want to point out that we are starting to stretch some of these bounds, and including patients with more than one lesion and even patients with a portal vein thrombosis V1 to V2. It's also important to know if the future liver remnant will support the liver to continue to work appropriately, and recurrence rates continue to be problematic, which has been estimated to be 70% at 5 years. And we know that transplant offers the best chance for overall survival in patients with HCC. However, we have a shortage of organs, and therefore patients are held to a standard by the Milan criteria. We do know that patients who are successfully downstaged to the Milan criteria have been shown to have similar overall survival compared to patients who met the Milan criteria from the time of diagnosis. And with that, downstaging has now been incorporated. OPTN has developed what eligibility for downstaging is. There is a ceiling, so not all patients would be eligible for downstaging. And I've listed this based on size and number. It's important to note this is a total tumor diameter up to 8 centimeters. And if patients are successfully downstaged to meet the Milan criteria, they are now allowed to receive a upgrade without having to go through what used to be called a special case. This highlights many of the adjuvant immunotherapy trials that are ongoing in patients who have undergone resection or ablation. This is limited to patients who are Child-Pugh A. The hope would be that patients who have undergone resection, that we can decrease the rate of recurrence, and therefore we would be more amenable to consider resection in patients as opposed to potential transplant down the line.
Thank you very much, Laura, for that great overview. And let's take a look as we are running out of time, but there are two quick questions I think would be interesting. Laura, can you comment on adverse events related to immunotherapy which might have a role or make us pause in earlier stage disease settings?
Sure. I mean, in earlier stage disease, when we have treatments that, 5-year survival is, 70%, specifically talking about single lesions with RFA and resection and transplant. If you were to start too early and a patient had a horrible immunologic effect that led to death, that would be of concern. So we know that this has been tested in people who have a more advanced disease, but in patients where you have other options that could lead to cure, you may want to really think about that before putting that person at risk of until we can better define what patients have a higher risk of immunotoxicity.
And I think the studies that are ongoing are well designed to answer those questions. Another thought from the audience, the TTF field data and technology sounds very interesting. What are other emerging technologies for liver cancer? So, one thing that is evolving is this idea of cell-based therapy, or CAR T, or T-cell therapies. These are engineered, typically autologous stem cells. Some of the targets are training T cells to attack alpha-fetoprotein expressing tumors, or another target would be glypican-3 that is in development. These are early on and evolving. Matt, do you have any thoughts on other technologies you're aware of?
Yeah, off the top of my head, I'm thinking about them. One is nanoparticles as treatment. There's been a lot of interest in that, but it's not yet made it to humans. This is bench research. One that has made it to humans and is in first in man is highly focused ultrasound. So using robotic assistance. So that has proven extremely impressive preclinically and is just now undergoing first in man. So we may see that in the future.
Very exciting. So in conclusion, I hope you found this useful. I think we've covered all these stages, but the one thought I want to leave you with, especially for this interventional radiology audience, is the intermediate patients where you have played such and continue to play such an important role. And that role includes downstaging patients from intermediate to early with curative intent. That also includes patients who get TACE as definitive treatment. But again, keep in mind that eventually those patients very well will progress. And at progression, you need to keep in mind all the exciting data and FDA approvals in not only frontline and second line and beyond for patients with advanced liver cancer. Thank you for joining us, and I hope you all stay well, and I'm confident we will all be together in person in the near future. Thank you again.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.